Real patient question. What's the best option for me? Direct to implant, two-step reconstruction with implants, or deep flap? A patient who has a B cup or C cup breast with nipples that are above the fold of her breast is a great candidate for just about any option for reconstruction, as long as she is not likely to have radiation of the breast. If a patient is having radiation, I don't recommend implants. But let's assume the patient is not planning radiation. In that case, she is able to choose between potential for direct to implant or an implant reconstruction. So I'm going to take that pathway. Direct to implant reconstruction is a great option for a patient who has a C cup breast with a little bit of deflation who wants a B cup or small C cup reconstruction. The risks of a direct to implant reconstruction would be that possibly there's a higher chance of developing an asymmetry. For example, as the breast heals, if one implant pulls down just a centimeter lower, it will cause a very visible asymmetry in the final breast result. I prefer a reconstruction in which implant location on the chest wall is controlled to the millimeter and nipple position is absolutely symmetrical. That is what I prioritize with a reconstruction. So I have some concerns when we think about a direct to implant because there's a possibility of creating slightly lower implant on one side or the other as the body heals. When we place that implant in the pocket after the mastectomy, we can line that pocket with a scaffold made of collagen that's derived from human skin. That's called alloderm. We create an internal support bra. We place that implant in the pocket, and then we close the skin over that area. So we have filled the breast with a silicone implant, creating an internal support bra. That's a direct to implant. That patient wakes up after the mastectomy with a final reconstruction. But statistically, that patient has a slightly higher chance of an asymmetry, which we talk about before surgery. And also, at least half of those patients choose to have fat grafting or another touch-up after surgery. We typically wait 3 months for a touch-up operation. Personally, for my body or for my recommendation, when a patient says, what would you do for yourself or for your sister? I like to use a tissue expander to create a controlled, exacting position for the breast on the chest wall, because that tissue expander has tabs that allow me to place the implant directly on the chest wall in the correct position. I then fill that expander to the correct shape and correct size for our planned breast. We wait 3 months, then we open that pocket, remove the expander, place our final implant, and at that time, we will do some liposuction, typically of the tummy and the flanks, filter and wash that fat with an antibiotic solution, and do injections of that fat along the cleavage and the upper breast and along that tissue to create a smooth contour from the chest wall onto the breasts so that we have a natural looking, soft, and healthy breast reconstruction. In my hands, I think that's one of the best results that we can get with an implant-based breast reconstruction. Again, for patients who know they're going to have radiation, I would prefer we move along the line of a deep flap or living tissue breast reconstruction.